I'm Dr. Larry Levine, professor of urology at Rush University Medical Center in Chicago. I'm also in private practice with UroPartners at that office in Chicago. Well, I've been doing penile implants for erectile dysfunction for over 30 years, but I've been involved with Himplant and prior to that, Pneuma since 2018. Well, the Himplant is designed to last for life. The silicone product is not something that breaks down, so it is durable. But certainly things can happen over the course of one's lifetime that may require us to consider removing the device or potentially adjusting the device if necessary. The good news is that does not happen very frequently, and so the device that you get may be the only device you'll ever need. So in my experience, penile sensation, both sexual sensation and just light touch sensation, does not tend to change over time. I call it Dr. Levine's 6-month rule, that it might take as long as 6 months for the sensitivity of the penis to come back to how it was beforehand. Let's realize that in the flaccid condition, the penis has very little sensation. In fact, it's almost like a limp piece of flesh hanging off the body. And I like to demonstrate that to patients by asking them to take their index finger, poke themselves in the penis, and then poke themselves in the belly. And when they do that, they can find that there's really very little difference in the flaccid condition. But when we get aroused, that sexual arousal feeling that we get down there that's so important, in my experience, that has not changed as a result of placement of the Himplant device. In the flaccid state, the penis will feel different because you now have something under the skin. The penis is more extended and full as a result of the device. And it's going to take just some time to get used to. And again, that's what I call Dr. Levine's 6-month rule. There can be variation in that in terms of how quickly things recover. And is there a possibility that there would be changes in how one perceives the penis? Certainly that's possible. But again, thankfully, in my experience, that has not been a long-term problem. And if anything, it's a short-term problem that resolves as the body gets used to the presence of the device. Well, I think that it's important to recover properly. And on the short term, which means in the immediate, maybe first couple weeks after surgery, I encourage my patients to be as little active as possible, as little active on their feet and in terms of exercise as they possibly can be. The reason for that is the penis is a dependent organ. It's hanging down, and tissue fluid will want to accumulate there if you're on your feet a lot. Now, assuming you've done all that and you've taken it easy for the first couple weeks, you can gradually increase your activity, but before resuming more strenuous physical activity like working out, swimming, vigorous exercise, biking, I usually recommend somewhere between 6 to 8 weeks and maybe some communication back and forth between me and the patient to make sure that the patient is ready to engage in that activity. And if they do engage in that activity and they start noticing, hey, I'm getting a little more swollen than I was beforehand, maybe you're not ready yet. Back off the activity maybe for another week and then try again. In time, the body will get used to the presence of the device. You'll have less discomfort, you'll have less swelling, and it'll be just part of you. And you won't even be thinking about it anymore because it becomes just part of your system. Well, in a sense, it is a new penis because we have the implant in, and so it's changed in terms of its size, its configuration, how it looks, and it will feel different because in the flaccid condition, the penis is soft, mushy, not really giving us much of a signal. Initially, as a result of placing the device, things will be stretched down there. You're going to be more aware of it in your pants at rest and things of that sort. But as I said, Dr. Levine's 6-month rule, it might not take as long as 6 months, but usually by 6 months, it very much becomes part of you. Having said that, still, when you touch the penis in the flaccid condition, you'll be able to feel the Himplant device under the skin. It will be more firm. The penis will have more extension to it. But the sensation in the glands, at least in terms of my experience, has been well maintained. It has not changed. Some men will perceive a little change in when they touch the shaft, that it feels less sensitive. But again, in the flaccid state, the penis is pretty insensitive anyhow. It really is what happens during sexual activity is that sensitivity preserved. Could it be altered? Would it be different for some men? I imagine it can be. So far, it has not been an issue in the last 3-4 years that I've been placing the devices with my patients. Well, size matters. That's kind of why we're doing this operation, of course. And so we want to optimize size, but we also want to optimize the cosmetic outcome. And so if you put in the wrong size device, that might end up having an improper looking penis. So we determine that primarily and ultimately in the operating room as to what is going to be the optimum and best size for that individual. And that's going to depend to some degree on the configuration and size of the glans penis, the head of the penis, the circumference of the shaft, again, in the flaccid condition, and the available skin. Some men have a lot of floppy skin. There may be more room to place potentially a little bit bigger device, but if you try to put that into a man who has tight skin, you might have too much restriction on the pneuma device, which could potentially result in a potential complication like a erosion or something of that sort. So we really have to be careful about making sure that we get the right size device in. We can get a sense of that during the initial consultation in the office, but the final decision will be made in the operating room. What I tell my patients is be sure to know that I'm concerned about size. I want to get the biggest device in that looks best for you. Peyronie's disease, as I explain it to patients, as best as we really understand it, is a wound healing disorder. And what that means is that the body's response to an injury, and I'll tell you, 80% of the patients I see don't recall an injury, but we presume that the penis gets overstretched, maybe during intercourse or masturbation, or there's a blow to the penis that might be minor, but that may be enough to activate the body's response to an injury. And that response is much more exuberant than you would expect relative to the minor nature of that injury. You then develop a scar which persists. Unlike in the normal situation, scar heaps up, but as the body heals, the scar undergoes what we call remodeling, and the scar ultimately disappears. But with Peyronie's disease, it remains. And that's really the critical part of Peyronie's disease, is the scar remains. And as a result, that scar, which represents an inelastic segment within the penis, persists. So I like to tell my patients that the penis is kind of like a balloon, long, skinny clown balloon. You blow up the balloon, it expands in girth and length in a very uniform fashion. But let's say we put a piece of tape on top of the balloon before we blow it up and then blow it up. What's going to happen? That area where that balloon is on top will not expand and the penis will get curved. If you put the tape around, it'll prevent expansion. You get indentation deformities, hourglass deformities, we call it. And that deformity will be persistent. The question really is, what do we do about that? And unfortunately, we do not have any reliable, rapid, or effective non-surgical treatment. There are a lot of things that we use that may make some scientific sense, and so long as it's not toxic and it's safe, we try those things. We can use oral medications of various sorts. We can do stretch therapy. We can even use various types of injections The only FDA-approved product right now is a drug called Xiaflex, but there's also verapamil and interferon that have been used historically with some success. The goal here primarily with non-surgical therapy is to prevent progression, particularly during the acute phase, which is the first year after onset of Peyronie's, and maybe even get some improvement. And what we see with non-surgical treatment is somewhere between 60 to 70% of men using those kinds of approaches may have anywhere from maybe 20 to 50% improvement of their deformity if they're a good responder. In those men who have persistent deformity, once they hit the so-called chronic phase, that would usually be about a year from the time of onset. Surgery tends to be the therapy approach. We have 3 different surgeries. If you have really good erections, then we determine the type of surgery based upon the severity of the deformity, curvature, and indentation. Relatively mild, moderate deformity, we can do what's called plication. We make little tucks on the opposite side to pull it up and make it straight. If it's more severe curvature, let's say in excess of 60 degrees, or you have a bad indentation, so the penis flexes like this, we call that a hinge effect, and you still have very good erections, we can cut out some of that scar tissue and insert a graft to correct the deformity. They come with their own kind of complications and risks, of course. The final option would be for men who don't have good, reliable erections, we put a penile implant, a prosthesis in to provide rigidity on demand, and then do straightening maneuvers to correct the curvature. I'll just add a little bit that in men who have mild Peyronie's disease, let's say a curvature of less than 30 degrees, or have a mild indentation that doesn't result in any instability, we have been offering pneuma Himplant devices to those men with some success in terms of masking over the indentation, correcting any narrowing, and maybe reducing the appearance of that mild curvature as well. Well, testosterone is a hormone, which means it's a chemical which circulates in the body and has an effect upon various tissues throughout the body. Testosterone is present in men and women, but it's at much higher levels in men than in women, and has important purposes. There are what we call receptors for testosterone, which means that testosterone will attach to that receptor, and that means it will have a purpose in that tissue, because once it's in the receptor, it will activate certain processes within the cell. Receptors are present in virtually every tissue in the male human body, meaning that testosterone has a purpose there. So it has a function in terms of sperm production. It has a function in terms of maintaining muscle mass, bone mineral density and strength of bone, bone marrow, liver function, skin health, on and on. Even thoughts now that testosterone is important in terms of cognitive function and prevention of development of dementia and other types of cognitive disorders. So testosterone is critically important. It has a fairly broad range. Most societies in medicine say that the range would be somewhere between 300 to 900. What's important here is that if the level is below 300, this would qualify for being so-called hypogonadal, having a low testosterone level. But not all men who have a low testosterone level have symptoms. So it's the combination of symptoms and low level that is the concern. And those are the patients I think are most reasonable to treat. And those symptoms would include low libido, erectile dysfunction, easy fatigability, lack of energy, lack of joie de vivre, wanting to pursue activities, just soon hang out on the couch and watch TV, finding it's hard to lose weight, even though you seem to be exercising regularly. These are all things that may accompany low testosterone in the adult. Replacing testosterone does not necessarily correct all those, but it can. And the question then is, how much do you need to give? That whole receptor concept that I mentioned before is very important. Once all the receptors are occupied, more testosterone is not better. So if the receptors are occupied, there's no need to be having a level above 8 or 900, because that's just going to be wasted. It's like taking way too much vitamin C. What happens to it? You pee it out. Testosterone will also be wasted in a sense if it's above a certain range. So you want to have proper occupation. And we believe that most tissues, the threshold level is met when you have a blood testosterone level of 300 or more. And so what I try to do with my patients is to normalize their testosterone, bring them into the normal range. By and large, I seek somewhere around 450 to 600. That pretty much guarantees that they're going to have receptor occupation and be able to potentially get benefits from that. It can take potentially anywhere from 1 to 3 months to know whether you actually are benefiting from it. Certain processes may be more quickly recovered, such as energy, libido may respond more quickly, erectile dysfunction may take a little bit more time, recovery of muscle mass may take a little bit more time. And I think it's critical if one is thinking about getting testosterone therapy is to go to somebody who is well versed in it, knows how to manage the potential risks of this therapy, because it does come, like with any treatment, there's potential risk. But I would also say that those risks are pretty infrequent and very manageable. Number one, testosterone replacement does not cause prostate cancer. Now, if you're an older man and you have a sleeping prostate, we call that a sleeping prostate cancer cell, yeah, stimulating higher testosterone may activate that cancer, but it doesn't cause it. It can also, in some men, encourage more rapid growth of the prostate, so they have urinary symptoms, slower stream, getting up more at night, not emptying well, things of that sort. But those are treatable. Probably the most common side effect would be excessive stimulation of the bone marrow. So we get too many red blood cells. And the thinking here is that a higher red blood cell mass may be more apt to potentially cause a blood clot, which could be problematic if it were to go into the lung or heart or something of that sort. Those are also infrequent and not clearly associated with testosterone. But 5% or so of men who do take testosterone will have an excessive reaction to testosterone, a higher level of red blood cells. And if that happens, then we either lower the dose, recommend phlebotomy, means periodically go getting a blood donation to maintain those levels in the proper range. And that's pretty much it. So it's pretty safe medication. And there's a variety of ways now of correcting testosterone. There are some oral pills which are available, hard to get, sometimes hard to get insurance to pay for. There's injection therapy, which have been around for a long time. There are various topical treatments, gels. There's even nasal sprays and things of that sort that can be used. So testosterone is, if indicated, is a good thing. We just have to make sure it makes sense.